In this urologic cancer video, we're going to talk about 4 different cancers, one of which you've already seen in medicine. You're not going to confuse one disease for the other, but there are 4 you have to know, and there's lots of little details about each one and potential pitfalls which make great board fodder. Let's start with the most important one because it's the most prevalent, and that is prostate cancer. Prostate cancer is a product of testosterone, 5-DHT. The more testosterone that's around, the more the cancer grows. This is a disease of old guys. So it's going to be an old man, generally greater than 70. And here's the thing, most people are going to die with prostate cancer, not from prostate cancer. In fact, most autopsies have some evidence of prostate cancer in it. So this is a big deal for the people who get very negatively impacted by it, but prostate cancer is a very manageable disease most of the time. Because of that, the USPTF has said we do not do asymptomatic screens anymore. We used to do PSAs and DREs on everybody. Now you should still do it for people who have a 1-degree separation of a relative who's had prostate cancer. It's an option you can offer. The reason why we don't do it anymore is because, 1, people die with it, not from it, and the morbidity associated with the diagnosis is too high. So you can offer it to your patients, but it's the wrong answer on the test. Instead, you should start thinking about prostate cancer when you have the obstructive symptoms of BPH. Hesitancy, frequency, trouble getting going, dribbling, failure to empty. Someone who has BPH is usually diagnosed on a DRE. In that digital rectal exam, not screening, but you're doing it because of the symptoms, what you'll find is not a smooth, rubbery prostate, but a firm, nodular one. So if you see the words firm, nodular prostate, they're pushing you towards cancer. If you think they have cancer because of a firm, nodular prostate, what you're going to do is get a PSA. This is the same test as it was for screening, only you're using it for a different purpose. It's diagnostic, and you're going to use it to ensure you got all the cancer if you take it out. After you get an elevated PSA, you need to go then take a biopsy. And the biopsy is done in one of 2 ways. It's either transrectal or transurethral. The reason why you want to do it transrectal is because here's the urethra running through the prostate. BPH grows into the urethra, causing those symptoms. Prostate cancer causes these big, nasty, nodular things, usually on the posterior, that are closer to the rectum than to the urethra. So you get a better sample if you take pieces through the rectum because you're targeting the area of cancer. You take 10 to 12 samples, and then you take the worst 2 and add them together. It gives you a Gleason score. The higher the Gleason score, the more advanced the cancer, the worse off you are going to be. That is, the less like the prostate it is, and the more like an undifferentiated adenocarcinoma it is. Once you have diagnosed prostate cancer, you're going to treat it. And the treatment is variable. Essentially, especially for mild disease, resection is equal to radiation, is equal to brachytherapy. You do some sort of semi-surgical removal of the prostate cancer. And then, because it's testosterone driven, we've got medications that can be used to suppress it. You can use anti-androgens, like flutamide. You can use GnRH analogs, and this is the preferred therapy, like leuprolide. We learned in the OBGYN lectures that GnRH is pulsatile, and if you give GnRH analogs, that pulsatility disappears and the whole axis is shut off, the HPA axis. FSH and LH aren't made, and therefore testosterone can't be produced. But since we're essentially castrating the person by blocking the androgens or by preventing their being made, if the cancer is refractory to these medications, you can do a literal physical castration, bilateral orchiectomy. Remove the source of androgens and the cancer can't grow. This is a great solution for someone who's a lot older and isn't using their penis for anything but urination anyway. As you begin to treat them, you're going to follow them up with a PSA. You want to see it return to 0. And then you continue to survey them with PSAs. If you have a rise in the PSA, but there are no symptoms and no signs of metastatic disease, that is biochemical evidence of recurrence without any symptoms, you use antiandrogens. And if it becomes metastatic, that is the PSA elevates, you have biochemical evidence of recurrence, and you've got metastatic symptoms, you can use radiation to zap them away. Again, you're going to die with prostate cancer, often not from it. And you have to deal with the complications of which choice you pick, and it doesn't matter which one it is, each one has its own side effects. Most often, urinary incontinence and erectile dysfunction. Lots to know about prostate cancer, the other ones are a little bit easier. The next one is bladder cancer. Bladder cancer is almost always going to be transitional cell carcinoma, and it is associated with toxic exposure to beta-alanine dyes, but most importantly, smoking. Beta-alanine dyes are used in sort of the painting and dry cleaning industry, which really aren't used anymore. Smoking is the most important risk factor, and exposure to cigarette smoking increases your risk of bladder cancer. The patient is going to present with painless hematuria. If you have frank hematuria and you're over the age of 40 and it's painless, you have to get worked up for bladder cancer. You might also see obstructive symptoms. And so if you see obstructive symptoms, you'd get an ultrasound to look for hydro. But only in the case of having the obstructive symptoms do you get the ultrasound. If you just have hematuria, you can begin the workup with the right test. The first one could be the ultrasound if you have obstructive symptoms, but the best test is cystoscopy. You put a camera up the urethra, you look into the bladder, and you take a biopsy. Most bladder cancers are very superficial, so what you can do is to treat them is simply remove them transurethral. You just remove the tumor and then either give intravesicular BCG or chemo. You only remove the bladder when the person has lots of recurrences or actually is invasive. But most of these bladder cancers do not invade the muscular layer and so can simply be removed from the inside of the bladder. You can do a cystectomy. And if you need to do chemotherapy, it's going to be cisplatin based. And if they've ever had one, they can have it again, so you want to increase surveillance by doing cystoscopies on them periodically and then removing the cancer as you find it. That's bladder cancer. Let's talk about testicular cancer. Testicular cancer is almost only germ cell, and so that's what we're going to talk about here. The patient is going to be young, generally 18 to 35. And they're going to find on physical exam, or they're going to complain of some like dull aching pain in their groin. What you'll see is a painless mass. And that painless mass does not transilluminate. Transillumination is basically you hold a flashlight up to the sac, and if you can see light through it, it's fluid filled. It's not cancer. A failure of transillumination, the light does not get through the mass, means that it's actually a mass, and that's more likely to be cancer. You work it up first with an ultrasound. And then having identified the mass, you might say, okay, this is cancer, I should go get a biopsy. Wrong. This is one of those pitfalls. You might think, I want to do a biopsy, so you do an FNA. All that's going to do is seed the tract. Do not do an FNA biopsy for testicular cancer. If you have a suspicious mass, you just cut it out. Orchiectomy is the way you diagnose it as well as treat it. Because you've done the orchiectomy, the treatment's already done. You've resected it. And then from that point, based on the stage, you might need to use chemo and radiation. So you remove that mass and you find out which one it is. And much like OBGYN, you want to separate these out into seminomas and non-seminomas. Seminomas are exquisitely sensitive to chemo and radiation, usually cisplatin based. The non-seminomas, not so much. But what you need to know about the non-seminomas is what you use to track them. So you can have an endodermal sinus tumor, the yolk sac, and you're going to follow that with an AFP. You can have choriocarcinoma. You follow that with a beta HCG. And then there's teratomas. And teratomas were benign in women, but they're often malignant in men. And that's the other pitfall. You see, teratoma usually comes up in OBGYN, but in men, it's very malignant. Don't leave that alone. You're going to have to look for metastatic lesions. The last one you've heard about in medicine already, so we'll go quickly through it. Renal cell carcinoma. The patient with renal cell is going to present with the classic triad of flank pain, a palpable mass, and painless hematuria. Now we're trying to get away from this, but the boards haven't yet. Only 10% of people are going to present with the classic triad. Instead, you're probably going to get painless hematuria and start working up the genitourinary system and find something on the kidney. Or you get imaging for something else, and then, oh yeah, there's a thing on the kidney. You may see the paraneoplastic syndrome of erythrocytosis because the kidney makes EPO, but you might also see anemia because the cancer is stealing all the blood. Really tough to identify the patient who has renal cell carcinoma, so likely they're going to give you flank pain, palpable mass, and painless hematuria, and you know to diagnose it, you're going to get a CT scan. And just like the testicular cancer, you might think, okay, there's a mass, I want to biopsy it, get an FNA. Nope. You do a nephrectomy to diagnose. Now, but I want you to feel this, and we talk more about this in the medicine videos. If you've got a cyst that's small and doesn't look like it's cancer, but you want to make sure, you can put a needle in that. If it's obviously malignancy, don't put a needle in it. You're just going to cause bleeding. Simply take it out. And of course, if you're going to need to, for metastatic disease, you're going to use chemo and radiation after the resection. But since you resected it, the tumor is already gone. 4 cancers, got to know a lot about each one. Prostate cancer, don't screen unless they have a first-degree relative who had prostate cancer. Your focus is going to be transrectal biopsy and then some sort of removal and then medications used to suppress the disease. Bladder cancer, smoking, painless hematuria, cystoscopy with biopsy, remove the tumor from the inside and only remove the bladder if it's invasive and metastatic. Testicular cancer, young guys, testicular mass that doesn't transilluminate, cut it out, no FNA. Renal cell carcinoma, flank pain, palpable mass, painless hematuria, see a mass on imaging, cut it out. That is urologic cancers. Become a better doctor. Subscribe now to get access to our premium content.